Well, good morning. As you all know, the COVID-19 pandemic prompted many changes to both how we practice medicine and how it's taught. The virtual classroom became the primary mode of curricular delivery quite quickly. And looking more closely at these adaptations, we've identified the utility in many aspects and ways to effectively provide didactic physician assistant education. Next slide. PA training includes a consistent process across all programs. We start with the preclinical phase, go on to the clinical phase, sit for the board exam, and then ultimately enter into clinical practice. For our program at UNC, this progression includes 12 months of preclinical training, which start in January each year, followed by 12 months of clinical training. In the preclinical year, students acquire the knowledge and skills that are foundational to prepare them to enter into the clinical environment. Adequate preparation is really essential for these students to be able to then further their learning while caring for patients. Introduce a global pandemic within the first few months of the preclinical year, and as you can imagine, this creates a substantial disruption. Next slide. So let's go back to March of 2020. There was a quick transition from in-person education to this entirely virtual delivery model on a platform we have all come to know so well, Zoom. And this involved synchronous and asynchronous content, modifying lectures, trying to increase student engagement, adapting kinesthetic skills training and assessment techniques, and so on. This rapid pivot really presented the opportunity for some innovative modifications. While students were assessed to ensure that their learning objectives were met, in order to really determine how effective these modifications were, we looked to a survey structure we already had in place to see how these changes really impacted how our students were prepared to enter into their clinical phase of education. Next slide. Each year, we survey our preceptors to assess their perceptions of our students' preparedness when they start their clinical year. This year, we administered that same survey and structured it based more on the competencies of PA education and practice, looking explicitly at things like medical knowledge, patient care, communication, and so on. Our preceptors were also asked to identify whether they had worked with our PA students in previous cohorts, and those individuals then received additional questions asking them to compare this cohort of students who had their training during our COVID modification times with previous cohorts of students. And in parallel, we also surveyed our students these same questions pertaining to the various competencies of PA practice and education to see how they felt their readiness to enter the clinical environment was. And then we asked them the same questions pertaining to how they felt these curricular modifications that they experienced due to COVID-19 impacted their readiness. Next slide. So our survey provided statements that pertain to each of these competencies and asked the respondents to rate how much they agreed or disagreed on a Likert scale, ranging from 1 of strongly disagree to 5 of strongly agree. So for example, with medical knowledge, the student was prepared with the appropriate level of medical knowledge for the clinical year. And as you can see, students and preceptors alike agreed that students were prepared with their medical knowledge. However, not unexpectedly, when it came to physical exam skills, both our students and preceptors identified a response that was closer to neutral and certainly below our threshold of comfort as far as agreeing with this statement. And this compares to previous cohorts where our preceptors responded with an average of a 4.0 or an agree. Interestingly, though, our preceptor ratings of communication and history-taking skills as far as preparedness were higher for this cohort than for all previous cohorts before this COVID-19 modified curriculum was delivered. Overall preparedness proved to be adequate as per student and preceptor feedback. Next slide. So, with more direct questioning about the perceived effects of the changed curriculum structure due to COVID-19, discrepancies did arise. So, our students overwhelmingly felt that these modifications led to deficiencies in their physical exam skills, whereas the preceptors were a little bit more split on how much of a bearing this had. You can see here for the pie charts, the kind of darker orange is a response of no, meaning that the individuals did not feel that these modifications led to deficiencies. In looking at overall preparedness, the majority of students felt that their overall preparedness was impacted by these modifications, whereas the majority of preceptors did not feel that that was the case. And this raises the issue of the students really perceiving that their experience was vastly different than that of other cohorts. Next slide. So some qualitative themes arose from these surveys where some optional comments could be provided. For our preceptors, they consistently cited students' limited confidence in their physical examination skills, as well as their level of discomfort with certain examination techniques. And our students overwhelmingly reported an inadequate amount of hands-on in-class practice time that they felt was problematic to their learning. These students, once we had this disruption in March, did not enter back into an in-person classroom environment until the final fall semester, in which case they were only in the classroom 1 day a week with hands-on practice time. Next slide. So though sparse, the literature in medical education has shown that virtual delivery can be done and can be done effectively. The academic achievement of PA students who were educated with some sort of asynchronous distance education compared favorably to traditional delivery models, showing really no significant difference in their achievement. And interestingly, the board passing rate for PA graduates from programs that offered some amount of undisclosed distance education online, those board passing rates were at least equivalent, if not greater, than the overall national average for board passing. And finally, instruction and physical examination skills for medical novices has been shown to be delivered equally effectively, whether it's live demonstration in person or online virtual modules. So obviously this can be done well and effectively. Next slide. So where do we go from here? Well, most of our curricular elements that were delivered largely virtually did not appear to be deficient. However, obviously some were, especially with the physical exam. So the elements of history taking, communication, very interestingly, our students were better prepared than previous cohorts, according to our preceptors. And we feel like continuing asynchronous delivery of some of this material would be appropriate moving forward. And we plan to really allow for in-person classroom time to have more of a focus on these kinesthetic hands-on skills. And we think it's important to continue that as much as possible. We will continue to look to our preceptor preparedness survey data to utilize the same kind of structure and see how these modifications over time affect our student preparedness, especially in regards to physical exam skills. This will be an ongoing project, and we also plan to survey our students' employers once this cohort is out in practice to determine how they feel their preparedness is with these same kind of competencies of PA practice. Ultimately, over time, we really hope to identify where this optimal sweet spot lies and how didactic physician assistant education is effectively delivered, and then share this information with our other program colleagues. Thank you so much.